All right, good morning and welcome to virtual boot camp. We're going to try to cover as much as we can in preparation for the predictor and the boards. We're going to do this probably for about 2 hours, hour and a half, 2 hours, or until I lose my voice, whichever happens first. So first thing we're going to cover is pharmacology. And I'm basically going to go down the line of the list of medications that you need to know. And remember, this list of meds is cumulative, and it starts back, way back when, in term 3, right, of the meds that for my day students, I was saying, make sure you know this forever, right? And for my night students, you're doing a great job of getting where you are, you're where you need to be, actually. So let's get started. We're going to do pharm and then fundamentals, and if we have time, maternal newborn. If not, we'll cover that next week. Pharmacology, what do you need to know? Start at the beginning. The first group of meds you need to know are the NSAIDs, non-steroidal anti-inflammatory drugs. These are anti-inflammatories that are basically over-the-counter meds. They all share commonalities as far as adverse effects. In other words, all non-steroidal anti-inflammatories have the potential to cause a GI bleed. So the list of meds that are in that classification are ibuprofen, meloxicam, which is Mobic, celecoxib, which is Celebrex, and naproxen sodium, naproxen, that's Aleve. And the one oddball in that group is celecoxib. And there are 2 additional things that you need to know about that drug. Celecoxib, if you're allergic to sulfa or sulfonamides, you can't have it. And if you have a cardiac history of blood clots, DVTs, you can't have it because it can cause blood clots. All right, NSAIDs. They're used for osteoarthritis, pain relief. The word analgesic means relief of pain, okay? And so they are used to decrease pain. They're also used as antipyretics. Pyrexia means fever. And so they can bring down your fever. They can decrease inflammation in joints. That's what you need to know about them, the end. Next, acetaminophen. Everybody knows Tylenol. So acetaminophen is not an anti-inflammatory. It's an analgesic, so it can relieve pain, and it's an antipyretic, so it can relieve fever. The one thing about acetaminophen that you need to know, hepatotoxicity. The maximum amount of acetaminophen that you can take in a day, 3 grams, 3,000 milligrams. Anything more than that can be hepatotoxic. So you want to say to yourself, who would I not give the drug to? I wouldn't give the drug to somebody with liver disease like cirrhosis or one of the hepatitis, right? Because they already have liver problems. I would pick a different drug to give them. Acetaminophen would not be the one. And as far as antidotes are concerned, there's an antidote for acetaminophen overdose, and that is N-acetylcysteine, aka Mucomyst. The next one on the list is good old aspirin, which is acetylsalicylic acid. Say that 3 times fast. So it's a salicylate, and it's an antipyretic. It is an analgesic, but it is also an antiplatelet aggregator. So it can be used on a regular basis, like if you see a patient that's taking a low dose aspirin or even a full dose. 81 milligrams is low dose. 325 milligrams is adult strength. And taking one every day is typically for cardiac. So in other words, person had an MI, and we want to try to help prevent them from having another one. So it prevents platelets from sticking together, clumping together and forming clots. So that's why it's used for that. One of the adverse effects, GI bleed, and another one of the adverse effects, salicylism. And salicylism means toxicity from too much aspirin, and it presents itself with high fever, chills, those kinds of things. And that's, you know, one of the things that we do with that is kind of wait it out, wait for it to pass. The next medication on the list, we'll talk about sumatriptan. ATI loves to ask about it. The board's not so much. But migraine headaches. Sumatriptan is used to relieve the pain of migraines. The trade name is Imitrex. The thing you need to know about it, it can cause a vasospastic response. So if the patient complains of chest pain, any kind of shortness of breath or pain in the chest that's intermittent, they should stop the drug and contact the provider. The end. All right, next on the list for pain, since we're talking about pain, is the opioids. All opioids have the same sets of potential adverse effects and side effects. And in that classification of opioids, morphine, morphine sulfate, codeine, fentanyl, hydrocodone, oxycodone, hydromorphone, meperidine, which is Demerol, and Dilaudid, and tramadol now too. So all of those are under the classification of opioid analgesics. Again, they are pain relief, moderate to severe pain. And what kinds of adverse effects do they share? Respiratory depression, urinary retention, paralytic ileus. They're the three big ones that can kill you. They do cause constipation, but nobody dies from that. So you need to know, before you administer an opioid, you are always going to assess the patient's respiratory rate. Vital signs, of course, but the most important one is their respiratory rate because it causes respiratory depression. Somebody ODs from opioids, they stop breathing, then their heart stops beating, right? So it's respiratory depression. Anything less than 12, you might want to contact the physician, right? Urinary retention. You want to think about other medications the patient's on, and you want to think about other diagnoses the patient has. For example, BPH, and this is an ATI. They love to ask this one. If your patient has benign prostatic hyperplasia, that causes urinary retention. You would be very judicious or cautious in giving them an opioid, giving them something that's going to cause more urinary retention, right? That just makes sense. So keep that in mind. If the patient is on an anticholinergic, anticholinergics can cause tachycardia, dry mouth, and urinary retention. So you would be cautious about administering opioids to somebody that's on that. Things you need to know. So if they're going to be on opioids, prevent constipation. That's an easy one. Instruct your patient, increase fiber in their diet, increase fluid intake. And you want them to increase fluid intake, not just because of the constipation potential, but also because of the fact that you want their body to be able to excrete the drug, okay? So either fiber, maybe a stool softener, increase fluids, and then be on the lookout for respiratory depression, urinary retention, and then last but not least is paralytic ileus. So post-operative patients, after surgery, patients have had an opioid for anesthesia, right? So after surgery, patients will be brought to something called PACU, post-anesthesia care unit, PACU. We used to say, shake them and wake them all day long. Easiest job in the world. Anyway, in PACU, they always keep naloxone on hand. Why? Naloxone is an opioid antagonist. It blocks the effects of opioids. So if a patient does in fact have a problem waking up or absence of bowel sounds, which is indicative of a paralytic ileus, we have naloxone on hand to administer. And if they didn't have any bowel sounds, after you've listened to each quad, 4 quads, 5 minutes each, because if you don't hear a sound, you keep listening for a full 5 minutes. No bowel sounds, you call the doctor. That's an emergency. That's a paralytic ileus. The ileum is the distal portion of the small intestine. So to remember the small intestines, DJ ileum, right? So duodenum, jejunum, ileum. The ileum is the furthest portion of the small intestine, which after having opioids can kind of seize, stop moving, lack of peristalsis. And if that happens, anything that's above it, anything in the jejunum or the duodenum, even if it's just air, is going to be trying to move down. And if it does, it's going to put pressure on that frozen part of the ileum, which can then rupture. So no bowel sounds for 5 minutes. You call the doctor. Patient's going to be strictly NPO, and they're going to drop an NG tube, right? Keep the patient NPO with an NG tube to low intermittent suction for gastric decompression. They're going to try to decompress what's above, and hopefully we're going to wait it out and it will resolve on its own. Most often it does. In the rare event that it doesn't, this poor patient's going to wind up with an ostomy temporarily, but it's a problem. So make sure you know all of that. And we talked about naloxone, which is the antidote or the antagonist for opioids. When naloxone is administered, there are two things that you need to know about that. If it's because of an overdose, understand that you must always call 911, even after you've administered it and the patient, wakes up. So let's say, you're on the street and you find someone who's OD'd from heroin, you administer naloxone because in this day and age, a lot of people just carry it in their car, You administer it, the patient comes to. You can't just assume, okay, they're good, let me just walk away. Because depending on how much opioid they have in their system, the naloxone will block the opioids for a period. But if the naloxone extends its own life before the opioids, then they're going to go into respiratory depression again. They need another dose. So you need to call 911. And if we give naloxone in an acute care setting, such as PACU, understand that if we give it too quickly, and we're probably going to give it quickly if you're not breathing, you're going to wake up in pain, right? Because you're going to have pain. You're not going to feel any of the effects of the opioids because the naloxone blocks the opioid receptor sites. So you're going to wake up in pain, but you're going to wake up and breathe, which is a good thing, okay? So know that. All right, so from that, let's move to cardiac, and cardiac's my favorite. Drugs that you need to know, and some of them I group together by classification. It just makes it easier. The queen mother of the cardiac drugs is digoxin, also known as a cardiac glycoside, also known as digitalis, also known as lanoxin. A lot of names for one drug. It's been around longer than me. And so digoxin is an unclassified antiarrhythmic. So what it does is it slows the heart down, slows down the rate, and by doing that, it helps it beat more effectively as a pump, okay? So you as the nurse, apical pulse for a full 60 seconds before administration. Not a radial, apical, okay? Because what you hear at the apical site, especially in older people, is going to be different than what you assess in a radial pulse because of things like arteriosclerosis, hardening of the arteries that comes with age, or atherosclerosis, that plaque that builds up inside the arteries, comes from high cholesterol, hyperlipidemia, and those types of things. So you always, even if you're not giving DIG, by the way, when you're assessing a patient, please don't let your first assessment be a radial pulse. It should always be an apical with the rate and the rhythm, okay? And remember, when you're assessing an apical pulse, it's the left mid-clavicular, clavicle, right? Left mid-clavicular line between the 5th and 6th intercostal spaces in between the ribs, okay? Make sure you know that. Make sure you know the locations of your pulses. Please, pretty please, okay? All right, back to DIG. Therapeutic serum digoxin level, 0.8 to 1.2. Anything greater than 1.5, toxic. They hit 2.0, you missed it. They're going to the hospital. They're going to get Digibind. Digibind is the antidote for digoxin. What else do you need to know? Signs and symptoms of DIG toxicity. Early signs, GI upset, loss of appetite, anorexia. Later signs, severe bradycardia. Makes sense. It lowers the heart rate. If you're toxic, it's going to lower it a lot, okay? And dysrhythmias that can be lethal. So if it adjusts the rhythm, you're toxic, the rhythm can go nuts. And then the weird ones are the blurred vision and the green or yellow halos around objects in the visual fields. Those are signs of toxicity. Make sure you understand that the biggest risk factor for digoxin toxicity is hypokalemia. So if a patient is on another medication, and they usually are, especially medications like loop diuretics, thiazide diuretics that deplete potassium, puts the patient at a higher risk for DIG toxicity. Okay? Okay, there's DIG. Next group of medications, diuretics. Diuretics are subclassified into three like subgroups. You have loop diuretics, which are furosemide, Lasix, and bumetanide, Bumex. You have thiazide diuretics. Metalazone is one, but you really need to know chlorthalidone and hydrochlorothiazide. And then you have one that is the opposite, is a potassium-sparing diuretic, and that is spironolactone. So loop diuretics and thiazides will deplete your potassium. Spironolactone will make you hang on to potassium, potassium sparing, okay? So what do you need to know? Of course, you need to check the patient's potassium level before administering, right? They treat edema. So they're used very frequently for patients with heart failure. So you will see patients with heart failure on DIG, an ACE inhibitor, and a diuretic. That is a very common and accepted use of those medications for heart failure patients, especially if they're class 2, class 3 heart failure. So you're always going to be on the lookout for DIG toxicity and hypokalemia, right, with any of those meds. All right, diuretics. And remember, with furosemide and bumetanide, if you're allergic to sulfonamides, sulfa, no. And ototoxicity and nephrotoxicity are two of the biggest adverse effects of those loop diuretics. Ototoxicity means toxic to your ears. So you can have hearing loss. And one of the first signs of ototoxicity is tinnitus. And tinnitus is that ringing or buzzing in the ears. Okay? So if the patient starts to hear ringing or buzzing in their ears, they need to stop the drug and call the doctor. Because if they have hearing loss due to the med, it's irreversible. And then nephrotoxicity goes and works on the kidneys. So, it kicks the nephrons in the kidneys into work in overdrive to pull fluid. And of course, it can damage the kidneys, but it's also used in kidney failure. Don't let me explain that one, but that's later down the road, right? So anyway, what are you looking at? BUN and creatinine. And remember the cardinal rule when we're talking about renal problems, renal insufficiency or renal damage. BUN elevated, maybe they're dehydrated. Creatinine and BUN, that creatinine is the one to look at. When that one is elevated, you're worried. That means that there is a problem. There's a renal problem. I don't know what it is yet. We have to dig a little more. But if that creatinine is elevated, that's the one where your brain has to go, nah. Okay? So those are diuretics. Next group, and I'm going to group these three groups together because all three of these following classifications are strictly antihypertensive drugs. And those are ACE inhibitors. They're your prils, right? Lisinopril, enalapril, captopril. Your ARBs, angiotensin II receptor blockers, and they are your sartans, losartan, valsartan. And then the last one is just one drug that blocks aldosterone, and that is eplerenone, okay? With all three of those classifications of medications, all the prils, all the sartans, and eplerenone, hyperkalemia is what you are worried about. Hyperkalemia, elevated potassium, okay? All of those drugs have the potential to make you hang on to potassium. And remember, potassium is queen mother of the electrolytes. When potassium is elevated or low, doesn't matter, high or low, your patient's going to have a heart attack, puts them at risk for severe dysrhythmias. You need to get them on an EKG, call the doctor, okay? All right, so, and then the prils have one more fun side effect, more so than the other two, and that's this dry hacking cough. Sometimes it's just an annoyance. Sometimes it's so bad that we actually have to stop the drug and put them on something different. So those are the ACE inhibitors, the prils, the ARBs, which are the sartans, and then eplerenone, aldosterone antagonist. Next, then we have two more classifications I'm going to lump together because these two work on the heart rate first, then the blood pressure. And they are the beta blockers and the calcium channel blockers. The beta blockers are the laugh out louds, LOLs, metoprolol, bisoprolol, timolol, propranolol, labetalol, okay? And those medications, again, bradycardia, beta blockers, bradycardia, remember it like that. They will slow the heart rate down, decrease contractility of the heart muscle. DIG increases the contractility and when it slows down the heart. The beta blockers and the calcium channel blockers decrease contractility, okay? Either way, they're going to cause possibly bradycardia and heart failure. Heart failure. So if your patient starts a beta blocker or a calcium channel blocker, which they are amlodipine, Norvasc, nifedipine, diltiazem, if they start those drugs and then a week or two later they come in for a follow-up and they've gained a few pounds, they have peripheral edema that is new, or pulmonary edema, you listen to their lungs and you hear crackles, your brain should go, probably the med, giving them heart failure, stop the drug, let the doctor know. Easy peasy. Boom. And that's the beta blockers and the calcium channel blockers. Vasodilators. Vasodilators, the big one you need to know, nitroglycerin. Nitro is a vasodilator, regardless of what form, and it can be given sublingually, buccally, which is a buccal spray, spraying in the mouth. There's nitro paste, there's transdermal nitro, and there's also long-acting oral nitro, and there's IV nitro, but don't worry about that, that's ICU. So nitro vasodilates. When you take it, it will open up all the blood vessels. And it does that, the blood can get through more easily, so therefore it relieves angina, chest pain. So let's talk about sublingual. Sublingual nitro. You can take up to 3 doses every 5 minutes. So 1 dose every 5 minutes times 3. And after the first dose, if there's no relief, you can still take your second 2 doses, but you need to call 911 because maybe you're having a heart attack. We don't know, okay? So it's 3 doses, 1 every 5 minutes under the tongue. If no relief after the first dose, you call 911. If your tongue is tingling, it's working. You get a headache, that's expected. The vasodilation, the blood rushes to your head, you're gonna get a headache, it's expected. Take some acetaminophen. You're going to feel maybe warm, flushed, right? It's expected, it will pass. Don't make any sudden moves. Don't try to get up quick because you may fall down. Because of the fact that when it opens up all the blood vessels, your blood pressure is going to plummet. Only makes sense because now the blood is flowing. Nice and easy. Pressure comes down, right? Hopefully your chest pain, your angina is relieved. If your mouth is dry when you're getting ready to take one, they wet the mouth with either like ice or a little sip of water or something, because if the mouth is too dry, it's not going to dissolve under the tongue, okay? Kept in a brown glass bottle for a reason. Nitro does not like sunlight, does not like heat. It should be kept in a cool, dark place if possible. Don't store it in the glove compartment of your car, too hot. They should carry it with them if they know they're going, going to be going maybe to bingo or something for several hours, just in case they start having angina while they're out. And they can take it prophylactically. So if you have a patient that has angina, but typically only with exertional activity, so, when the patient's, vacuuming, the patient can take a nitro about 15 to 20 minutes before that activity, prophylactically to help prevent angina, okay? Then within nitro, we'll talk about the nitro transdermal patch. You want to put the patch on an area where there's little hair as possible. If you do have somebody who's a hairy person, never shave the hair. You can trim it a little bit with scissors if they're really that hairy, but don't shave because that increases the risk of infection. We don't ever shave patients, ever, anymore. Evidence-based practice. Rotate sites to avoid irritation of the skin. Nitro patches are put on in the morning and removed in the evening, usually anywhere from 8 to 12 hours on and then off. So you should always put your initials, date, and time when you put it on. So this way, if I'm the nurse behind you, I can look and say, oh, she was here. She put this on at 8 o'clock this morning or whatever. So I know how long it's been on, okay? You should always wear gloves. Of course, when you are putting it on, you don't want to get any of that on your hands because that's transdermal, it can go right through to your skin. When you dispose of it, you should always, and this holds true for all transdermal patches, should be folded into itself so that the area that was touching the skin is not exposed, and then dispose of it, okay? With the nitro paste, that is applied on a paper applicator, and it has calibrations on it. It looks like a ruler, and the calibrations are marked in 1/4 of an inch, 1/2 an inch, 3/4 of an inch, like a ruler. And the order will be apply nitro paste, anterior chest wall, 1/2 an inch daily. And you literally squeeze the tube onto that paper applicator that's calibrated, 1 inch, 1/2 an inch, or whatever. Apply it to the anterior chest wall with a clear, occlusive dressing over it. And it's the same principle as the patch, and it's 8 to 12 hours on, off at night, okay? Okay. So that's nitro. Talk about the statins next. Let me get a sip of coffee. Hyperlipidemia, hypercholesterolemia. There are treatments. One of them are the statin drugs, atorvastatin, simvastatin. So the statins are used to lower the bad cholesterol. And remember, total cholesterol, 200 or less, but more important is your HDL and your LDL. HDL, high density lipoprotein, that's the heart healthy one. H is good. You want that as high as possible, greater than 60. LDL, bad cholesterol, low density lipoprotein. The lower number, the better, less than 100, okay? And the statins help to lower that bad cholesterol. But the statins can cause something called rhabdomyolysis, which is a deterioration or a breakdown of muscle tissue that releases these enzymes. It's deadly. It can kill you. So if the patient has a new onset of muscle cramping, muscle pain, anything like that, after starting a statin drug, stop the drug, call the healthcare provider, because that can be fatal, okay? And all the statins have that commonality. They should be taken at bedtime. They're better metabolized and absorbed at night. And they should never be taken with grapefruit juice. Okay, the end. The other medication that's used, and it's really a B vitamin, it's vitamin B3, which is niacin, is used typically as an adjunct in the treatment of hypercholesterolemia, hyperlipidemia. And the one thing you need to know about it is that it'll make people get this really hot flushing feeling when they take it. Just tell them to take a full strength aspirin 30 minutes before they take their niacin. And that will prevent that flushing feeling from occurring. And that's it for niacin. Okay. That's it for hypercholesterolemia drugs. The next category will be anticoagulants. 3 that you need to know. Warfarin, which is oral, also known as Coumadin, also known as Jantavin. Enoxaparin, sub-Q only, also known as Lovenox. And then the queen mother of the anticoagulants, heparin. And if you look at the spelling, you'll see P-A-R-I-N at the end, right? Or at least A-R-I-N. So heparin, warfarin, enoxaparin, right? And that's how you recognize them as the anticoags. They do not dissolve clots. They prevent the formation of new clots. And if somebody has an existing DVT clot, it'll prevent it from getting any bigger. But it doesn't dissolve a clot. None of them do. So we'll start with the queen mother, heparin. Heparin can be given IV or sub-Q. And heparin works fast. So if you come to the hospital or you're in the hospital, we can give you heparin. It's called getting heparinized. And it's going to work quickly. And it's going to slow down the clotting process. It does not thin your blood. It's a pet peeve. You guys that all know me know that I say this all the time. They're not blood thinners. Okay, lay people call them that. What they do is they slow down the clotting process, right? So heparin, IV or sub-Q, fast acting, and the tests that you're going to be looking at before you administer heparin are the activated prothrombin time or partial thromboplastin time, sorry, APTT or PTT. Some people remember it because when you write the letters PTT, the TT looks like an H, which stands for heparin. So if that works for you, cool. But just know that with heparin, that PTT is the lab that you're looking at, partial thromboplastin time or the activated partial thromboplastin time. The antidote for heparin, protamine sulfate. And that's one of those antidotes that you need to know. Protamine sulfate is the antidote. The next one is a low molecular weight heparin. That's enoxaparin. That's given subcutaneously. So we give that in facilities, and people are also sent home sometimes because it's given sub-Q. It's given just like insulin, right? And so it's, sometimes we can teach patients or patients' family members to administer it. But it's a low molecular weight heparin. So it works way quicker than warfarin, not quite as quickly as heparin. It's in between the two. You'll see that one used a lot prophylactically for patients that are having, say, orthopedic surgery, and we know that they're at risk. So we'll give them enoxaparin for, a little bit, right after the surgery to make sure that they don't develop a clot while they're recovering from surgery. And then warfarin, the last one, is only given orally, and warfarin works slowly. And so you may see a patient that's on heparin, and then they're also on warfarin orally. And, why is that? Well, the why is because the heparin is going to work quickly from one angle to anticoagulate them. It's going to take a minute for the warfarin, usually a few days up to a week. And so we're going to be checking the patient's PT-INR. Specifically, the INR is the one that everybody's looking at. International Normalized Ratio is what that stands for. And they should be between 2.0 and 3.0. Okay? That means that they're therapeutic. So once they get to that level, the doctor will usually stop the heparin and just keep them on the warfarin. Okay? With all the anticoagulants, okay, all three of them, the same safety rules apply because the risk for bleeding. Oh, and the antidote for warfarin is vitamin K, phytonadione. So the safety measures, you never use a razor, nothing sharp. Don't run with scissors. They should use an electric shaver. Ideally, they should wear a medical alert bracelet because if something should happen and there's a trauma, they're brought into the emergency room, we can see right away, oh, this patient's on an anticoagulant. We need to give them their antidote so that they don't bleed out while we're treating them, right? So medical alert bracelet, no sharp objects, fall preventions, no extension cords, throw rugs, those types of things in the home, because if they fall, they hit their head, gonna have a subarachnoid hemorrhage, potentially. Brush their teeth with a soft bristle toothbrush, and that applies to all of those, okay? And you're gonna warn them about signs of bleeding. Make sure you know petechiae, and I know that you guys have all heard that. Petechiae are those little red marks that patients will have, and they're generalized. That's a sign of bleeding, right? So sometimes we have to, be aware of, the patient's use of medications, especially when they're on warfarin at home. Dietary instruction for warfarin with regard to vitamin K. And oh, by the way, don't confuse vitamin K with potassium, which is represented as a K. So potassium is an electrolyte. Vitamin K is a vitamin stored in the liver. Okay, it's a fat-soluble vitamin. And vitamin K is found very readily, mostly in green leafy vegetables. So it's found in spinach and kale, and even quinoa has it, if you're a hipster. You want to tell the patient to be very consistent with their diet, because if they have a lot of salads this week, then what's going to happen? All that vitamin K that they're taking in is going to lower their INR and put them at risk for a clot. And then next week, they decide they want to have a salad every day, or they don't have any salads, I'm sorry, and then their INR is going to go in the opposite direction. So if they're going to eat these vegetables, particularly that are loaded with vitamin K, consistent. Going to eat them 3 times a week, always eat them 3 times a week. Don't have them every day, 1 week, and then not at all the next week, because we won't know how to dose you. Okay? And that's it for the anticoagulants. And then there's one more antiplatelet aggregator. We talked about salicylates, aspirin, but there's clopidogrel. Clopidogrel, which is Plavix. It's an antiplatelet aggregator. So it's not quite an anticoagulant, but almost, right? Keeps your platelets from sticking together. Really what you need to know about that one are the same types of bleeding precautions. And then you're always going to teach your patient, you know, if you have black tarry stool, melena, call the doctor. Petechiae, call the doctor. You suddenly develop ecchymosis, bruising, without a reason. Not that you fell down or you banged yourself, but I mean, just you wake up in the morning and go, those black and blue marks weren't there yesterday. You need to call the healthcare provider. Those are all potentially signs of bleeding. They should also be looking at their urine to make sure that there's no hematuria, right? Anytime the patient's on a medication that has the potential to delay the clotting of blood, which are the anticoags and the antiplatelet aggregators, all of this instruction is necessary to the patient, okay? To make sure they understand what these signs and symptoms of bleeding are and things to prevent a bleeding emergency. Okay, that's the anticoags and antiplatelet aggregators. I am going to pause recording and take a quick break and stand up for a second. If you have any questions about what we've covered so far, put them in the box, Felix. Okay, so I'm going to pause real quick. Go. Okay, so now we're going to hit the endocrine system. Endocrine meds, let's start off with hormones, and I'll tell you my joke later. Anyway, so we'll talk first about estrogen. Estrogen, female hormone, key ingredient in oral contraceptives like the pill, right? And sometimes it's estrogen and progesterone, but estrogen is always a component in the birth control pill. Estrogen, problem side effects that you need to know. Number 1, cardiac history. Estrogen can cause DVTs, blood clots. So if anybody has any cardiac history, or over 35 and a smoker, or either of those things, but especially both of those things, no estrogen, because it can cause an MI. They can throw a clot. And then the other thing to know is female reproductive cancers. In other words, breast cancer, uterine cancer, cervical cancer, ovarian cancer, vulvar cancer. All of those cancers, most of the time, not all the time, but most of the time, are fueled or fed by estrogen. So if the patient has a history of any of those female reproductive cancers, or they have a family history of breast cancer, cervical cancer, ovarian cancer, uterine cancer, whatever, estrogen is not the drug for them because it will increase their risk. And that's really what you need to know about estrogen, okay? And then anabolic steroids. Don't get steroids in general confused. So there are corticosteroids like prednisone, prednisolone, methylprednisolone, solumedrol. And then there are anabolic steroids. The word anabolism means to build up. So when you see anabolic steroids, I want you to think of the guy at the gym that doesn't have a neck. That guy. Anabolic steroids, they're also called dope or juice. And so what they do is they build muscle mass fast. And by the way, they're illegal. So anyway, when you hear about doping scandals with athletes, that's what they're talking about. They're referring to anabolic steroids. So what you need to know about those, you know, younger boys especially, and this is the question that you're going to get, you know, adolescent boys with anabolic steroids, if they get their hands on them, it will stunt their growth. Okay, so they're going to get jacked, but they're going to be 5'2", right? And then, fun fact, testicular atrophy, their balls will shrink, and that's always fun. And then roid rages, okay? A roid rage occurs when the patients have these high levels of anabolic steroids. They will fly off the handle for very little. There's too much cream in my coffee. Ah! So that's all you need to know about anabolic steroids is that it stunts their growth, testicular atrophy, can't even say that without laughing, and the roid rages. Okay, next, let's move to, real quickly, diabetes insipidus and SIADH. So diabetes insipidus waterfall. When you see that, diabetes insipidus, I want you to hear me. Waterfall! Patient just pees and pees and pees and pees and pees and pees and pees. And it's because they don't have enough or any antidiuretic hormone from their adrenal glands, okay? ADH. And then SIADH, syndrome of inappropriate antidiuretic hormone, they have too much ADH. And the only reason I'm bringing it up is because one drug you need to know, vasopressin, also called desmopressin, is the treatment for diabetes insipidus. It is a man-made antidiuretic hormone. Vasopressin, also known as desmopressin, will treat diabetes insipidus. If they have SIADH, that means they're holding on to fluid, we'll give them diuretics. That's pretty straightforward. Okay, next let's talk about the thyroid. So your thyroid gland is the only endocrine gland that you can actually palpate. It's right here at the anterior throat. You have the patient hyperextend their neck and swallow. You typically can feel part of it. If a person has a hyperactive thyroid gland, hyperthyroidism, sometimes you will see a goiter, especially with Graves' disease. Graves' disease is an autoimmune disorder that is the #1 cause of hyperactive thyroid. And the two commonalities that Graves' disease will cause are goiter, which is an enlarged thyroid gland, sometimes really big, that you can see, big swelling lump on the neck throat area. And then the other thing is the googly eyes, boing, exophthalmos, okay? So caused by Graves' disease. Wendy Williams, the eyes like, boing, look like they're gonna pop out of her head. So that's exophthalmos. If a person has a hyperactive thyroid, everything fast and high, right? So tachycardia, hypertension, oily skin, because the sebaceous glands are in overdrive, diarrhea, because the bowels are in overdrive, high temperature, because the metabolic rate's in overdrive, insomnia, right? All those things that go along with the hyperactive thyroid, fast, everything's fast, right? They will eat and eat and eat and eat and not gain a pound, right? Just super skinny because their body's just burning up everything that they're taking in. And so with a hyperactive thyroid, #1, labs, remember this, for all thyroid evaluation, you're looking at the TSH, thyroid stimulating hormone, and T3 and T4. Whatever the thyroid is doing, the T3 and T4 will match it, and the TSH will be the opposite. In other words, hyperactive thyroid, T3 and T4 are elevated, TSH is low, okay? TSH will be low, but the T3 and T4 will be high along with that hyperactive thyroid gland. If they have hypothyroidism, thyroid's slow and sluggish, then the TSH will be high, but the T3 and T4 will be low, okay? So remember, the T3 and T4 match whatever the thyroid's doing. If the thyroid's going fast, T3 and T4 are elevated. If the thyroid's hypoactive, slow, T3 and T4 are low. Then the TSH is the opposite, okay? Treatment, meds. So for hyperactive thyroid, you have methimazole, propylthiouracil, radioactive iodine, thyroidectomy. They're your options. So methimazole and propylthiouracil, treatments for hyperactive thyroid disease. They're meant to slow down the activity of the thyroid gland. And really, believe it or not, the biggest problem is that they'll slow it down too much, right? And then the second problem is an issue with agranulocytosis, having not enough white blood cells, okay? And that's really what you need to know about those. Excuse me, 1 second. Let me pause recording 1 second. Okay. The third thing is the radioactive iodine. Now, radioactive iodine is more of a medication and a treatment because it's iodine and they have radioactivity in it, and it's meant to shrink that swollen thyroid. That they must do that prior to a thyroidectomy, because if it's not done properly before they go in and remove the thyroid gland, one of the complications after post-thyroidectomy is thyrotoxicosis or a thyroid storm. And what that means is that all that T3 and T4 is in the bloodstream, and it just sends the whole body into this horrific overdrive. Hypertension, tachycardia, hyperpyrexia. So they'll present with a really high fever, a really high heart rate, and a really, really high blood pressure. And all we do is we have to treat those symptoms, right? And kind of like ride it out, wait it out. And then the other post-op complication, and I'm going to throw this in, is a problem with hypocalcemia. And the reason is, that's right. Why? The parathyroid glands are itty bitty teeny tiny next to on either side of the thyroid. And when they go in and remove the thyroid, they can accidentally nick or even remove the parathyroid glands. The parathyroids control a hormone called calcitonin. Calcitonin is a hormone from the endocrine system that balances the level of calcium in the blood and the level of calcium in the bone, right? And remember, I say this all the time, when you think potassium, you think muscle. When you think calcium and magnesium, you think nerves, right? Low calcium in the blood, hypocalcemia, will present with nerves being hyperactive. And that's when you're looking for that Fostek sign. So we're tapping on the facial nerve at the cheek will make the mouth like twitch, or the Trousseau's, which is where you put the sphygmomanometer on the patient's arm. And when you inflate it, their hand will go, and that's tetany, right? So it's hyperactivity of the nerves, common post-op complication after thyroidectomy. Okay, so that's propylthiouracil, methimazole, radioactive iodide, and thyroidectomy. Now let's go the other way, hypothyroidism. And what you need to know about hypothyroidism, really the drug is levothyroxine, also known as Synthroid. Potassium muscle, potassium muscle. Right. Okay. I'm looking at these little posts people are putting up. So levothyroxine is used for hypoactive thyroid, and it's basically like a man-made thyroid hormone. And the biggest issue, it needs to be taken first thing in the morning on an empty stomach by itself, full glass of water. Okay? Full glass of whatever, but not Jack Daniels. Or I mean, okay, Jack Daniels if you want, but probably not recommended.
It was supposed to say water. I don't know what happened. I said, what?
I thought that was funny. So anyway, so yes, got to be taken by itself first thing in the morning, full glass of water, and you want to wait at least a half an hour, but ideally an hour or so before they take any other medications, right? The biggest problem with levothyroxine is the dosage of it. So you want to be watching the symptoms. So in other words, if they have a hypoactive thyroid, they're lethargic, they're fatigued, their vital signs are all low, they're always cold, their skin is dry, they're constipated, right? All of those things are symptoms of a hypoactive thyroid gland, right? And so is the levothyroxine fixing that, right? That's evaluating the effectiveness of that medication. Are those symptoms better? But then, are those symptoms going too far the other way? That's the biggest problem, right? And so you're always going to be watching to make sure. It's the biggest concern with levothyroxine. Is it too high a dose where now they've become tachycardic or hypertensive? And really, other than that, you know, and yes, they must take the drug for life. And that's it for thyroid. Now let's go to diabetes mellitus, type 1 and type 2. And I'll just give a real brief kind of overview. So type 1 diabetes used to be called juvenile diabetes, and that is the one that has a very fast onset. So like you're fine one day, and then the next day, boom, you are not. Not gestational. Not gestational. Gestational diabetes is when you're pregnant, right? So type 1 is genetic and it's autoimmune. Type 1 diabetes is genetic and it's autoimmune. So in other words, your pancreas just is not making any insulin because your immune system is attacking it and your cells are resistant to any insulin at all. It's autoimmune. Remember that, okay? And if you have type 1 diabetes, like I said, it's usually young people, anywhere from childhood up to like early 20s, mid 20s, and they're fine one day, and then the next day, boom, they'll pass out, bring them to the emergency room, blood sugar's 800. You heard me right, 800 or more, okay? And so they need insulin, and they will be insulin dependent for the rest of their lives. There's no other treatment for type 1 diabetes. It's only insulin. Now, type 2 diabetes is the one that you can kind of bring on yourself. So in other words, it is, you have a genetic predisposition for it. In other words, if your mom has it or your dad has it or sister, brother, aunt, that increases your risk, but it doesn't mean it's a guarantee that you will get it. Whereas type 1 diabetes is congenital, so it's in your DNA, right? So the difference. Type 2 is not a sudden onset. It's insidious. It kind of creeps up on you. And people can really bring it on themselves because of sedentary lifestyle, obesity, and poor diet, lots of bad carbs. And this is where I will include nutritional education because this is important, right? Very important. And so type 2 diabetes, it's insidious. You eat a lot of the bad carbs, which are the simple carbs, the white sugars. If it's white, it ain't right. They're the ones that when you take them in, your blood sugar will shoot up. It's fast in, fast out, right? Blood sugar shoots up and then blood sugar drops. Okay, quick acting are the white sugars, the simple carbs. And the simple carbs are really anything that is white, okay? So white rice, white pasta, white potatoes, white bread, white flour, white sugar, all of those things. And of course, candy and cakes and donuts are all made with white sugar and white flour. And there you go, right? So people that have a high intake of those foods they're increasing their risk. We have more type 2 diabetics in this country than ever. And the numbers are just constantly going up because people are sitting on their devices, on their laptops. They sit, they don't move, they don't sweat, and they eat wrong, okay? So they can bring it on themselves. And back to the carbs, the complex carbs, they're the ones that are brown. They're the ones that are long acting. They will keep blood sugar stable for a lengthy period of time. Brown rice, brown pasta, the brown breads like whole grain, multi-grain, rye, wheat, right? Those are the complex carbs. And they'll last for a long time. They'll keep blood sugar stable instead of having that up and then down, right? With diabetes, a person can live with diabetes, type 1 or 2, and never have a complication if they manage their diet and their medication regimen and don't have these spikes, these erratic blood sugars that go up and down and up and down. That is the cause of the diabetic complications, those erratic blood sugars. When diabetes is managed right, you can go through your life and never have a complication. But problem is, people get tired and they tend to cheat. I don't even like to call it cheating because imagine if you had to stick your finger 4 times a day, every damn day, and then stick yourself with insulin, right? I mean, that's got to be horrible to live. So you'll find that it's difficult to manage. Every time the blood sugar gets elevated, All that sugar that's in your blood, and your blood is everywhere in your body, it's just eating away at the little tiny blood vessels and the little tiny nerve endings, especially the tiniest ones, which are furthest from your torso, your feet and your legs, diabetic peripheral neuropathy, kidneys, diabetic nephropathy, and your eyes, diabetic retinopathy. Those are the three biggest complications of diabetes that is not well controlled, well managed. Okay. Just imagine, and I always say this, put your baby to bed with a bottle of Pepsi every night, or a bottle of chocolate milk, right? All that sugar, what's going to happen to their teeth? It's going to just eat away at their teeth and rot their teeth. Same principle. Every time there's a spike in blood sugar, all that sugar in the blood is just eating away, and the patient winds up with visual loss, blind. They wind up with peripheral neuropathy, that starts with pain, and then it ends with them having no sensation at all in their feet. And then diabetic nephropathy destroys their renal function, and they wind up on dialysis. So they've been amputated, they've got, one lower extremity amputated, on dialysis, and they're blind, and their nickname is Stumpy. Not funny, but you want to make sure your patients understand the risks of poorly controlled blood sugar. Nobody wants to live like that. It's horrific. Okay. So what do we use as far as insulin and orals? Remember, type 1 diabetics only get insulin. Type 2 diabetics, we will always start out saying, hey, change your life, right? Modify your diet, modify your lifestyle. In other words, like get some exercise, move. If that doesn't work, then the drug that we will go to typically first is metformin. Metformin is not an insulin. It does not cause hypoglycemia. It has nothing to do with your pancreas. It is not an insulin, right? Metformin inhibits hepatic gluconeogenesis. And I love when term 3 students do their templates and write that down, and I go, explain that. It's real simple. When you eat foods with sugars, insulin, when you're healthy, takes the sugar and feeds your cells and takes whatever's left and brings it to your liver to store it there. Later down the day, you don't eat for whatever reason. You're a nurse and you're working a 12-hour shift and you didn't have a break. You don't eat. Blood sugar starts to drop. Your liver can take that stored sugar, which is glycogen, convert it into glucagon and put it back into your bloodstream, is a usable form of sugar. That's gluconeogenesis. Metformin stops the liver from doing that. Don't do that, liver. So metformin is used along with diet, exercise to lower blood sugars, but it's not insulin. It does not cause hypoglycemia like the other orals or insulins do. Okay? What do you need to know about metformin? Metallic taste in the mouth. Tell them to suck on some sugar-free hard candy. It can cause a significant side effect, adverse effect called lactic acidosis, which is fatal. It's very similar to rhabdomyolysis that we spoke about with the statin drugs. And so it's a breakdown also of muscle tissue because of an overproduction of lactic acid within the muscle that eats away the tissue and sends the enzymes in the bloodstream, and you can wind up dead. So again, new onset of muscle pain, muscle cramping, something like that with metformin, you want to call the doctor, stop the drug. And then the third thing to know is that if a patient is going for any type of procedure that involves contrast dye, an angiogram, coronary angiography, cardiac catheterization, CT scan, anything that needs contrast dye, intravenous pyelogram, IVP for their kidneys, they must hold the metformin the day of and 2 days after the procedure, or we will put them into renal failure, because the kidneys will not be able to excrete the contrast dye and the metformin. Can't do it. And so they'll go into renal failure. That's what you need to know about metformin. And okay, let's talk about 2 other oral anti-diabetic drugs, acarbose and exenatide. What do you need to know? With exenatide, it can cause pancreatitis. That is an adverse effect of exenatide. It works, it affects the pancreas. So if the patient has this sudden onset of severe abdominal pain, stop the drug, call the doctor. Yeah. Acarbose has to be taken with each meal, with the first bite of each meal, not before it. Like when you sit down to eat, have your pill ready. I'm going to eat, take my pill, and I eat with the first bite of every meal. Acarbose. The end. Okay. Now let's talk about the insulins. What do you need to know? Rapid acting insulin, which is Lispro. Short acting, which is regular. Intermediate acting, NPH. Long acting or basal insulins, which is insulin glargine, which is Lantus, or insulin detamir, which is Levemir. So I'm going to start with the long acting and kind of work my way back. So long acting or basal insulins, and ATI and the board, they love to ask about glargine. That's their fave. And so insulin glargine, given at bedtime typically, it's given once a day. It has no effect on the instant blood sugar. In other words, it doesn't cause hypoglycemia, okay? Which I see that written sometimes, and I'm like, no, look back in F.A. Davis, right? Doesn't have that propensity to cause the hypoglycemia because it's slow and steady. It's meant to work over a 24-hour period to lower blood sugars. So it's given by itself, never mixed with anything else. It's given subcutaneously. And understand with subcutaneous injections like insulins, you must always rotate the administration sites to prevent lipodystrophy. You need to know that word, lipodystrophy. Lipo meaning fat, dystrophy meaning like breakdown of. So lipodystrophy is basically scar tissue. If you keep on giving these injections into the same spot over and over again, scar tissue is going to build up. And eventually what will happen is you will administer the insulin into that area, that scar tissue and the fatty tissue, and the medication won't absorb. And so it's like you didn't even take your insulin, okay? Lipodystrophy, sure you know that. All right, so let's see, the long-acting insulins. You would never hold a long-acting insulin based on a blood glucometer reading. That's not how it works. The long-acting insulin, like I said, slow and steady wins the race, okay? NPH, the intermediate, oh, and by the way, the long-acting insulin, glargine has no peak, it's just slow and steady, okay, no peak. NPH is intermediate, it's the only insulin, when you look at the vial, it looks cloudy, okay? And so it is intermediate acting, 4 hours to about 14 hours, 12, 14 hours, okay? And what you will never see, but you will be tested on, is mixing NPH and regular. And that's that Nancy Reagan RN, right? Or Nicole Ritchie RN, NRRN. So regular insulin was historically mixed with NPH. We did it for years because we didn't have long-acting insulin back when, you know, dinosaurs were roaming the earth when I was first nursing. And so what you would do is you would mix regular insulin based on that sliding scale to treat that blood sugar now, but then you'd mix in some NPH, and that was meant to try to hold the patient over for a longer period of time during the day. So maybe you didn't have to give them a second insulin shot at lunchtime or at dinner, right? That was the whole thought process. That's why we did it. So Nancy Reagan RN is mixing the NPH, regular NPH. Just remember it like that. You drop the air first into the syringe, and then you drop the regular insulin, and the NPH insulin is always last, okay? So make sure you know that. Regular insulin is the only insulin that can be given IV as well as subcutaneously, okay? Insulins are administered sub-Q, but regular insulin can be given intravenously, and that's to treat diabetic ketoacidosis. And I'll talk a little bit about that too. So regular insulin is short acting. when you see a sliding scale, and the sliding scale says, all right, blood sugar reading below 60, administer D50, dextrose 50, right? You want to give them some sugar because their blood sugar is too low. Blood sugar 61 to 140, no units. 141 to 200, 2 units. 201 to 300, 4 units, or whatever, right? That's a sliding scale. So it's like a standing order. You check the blood sugar, whatever the reading is you get, you administer this much insulin, right, to address that blood sugar. So it's short acting. The onset and peak, remember, onset of regular insulin within 30 minutes or so, peaks hour, hour and a half, 2 hours. And so you want to make sure that they're going to have food, right? If you're going to be administering morning insulin. Okay. So you go in, you check the patient's blood sugar, 200, you give them their insulin. Make sure that the breakfast trays are coming before you give them that insulin or you're going to bottom them out. Right. Make sense? Okay. And then Lispro is rapid. Lispro, they better have some food in front of them 15 minutes after you give it, because Lispro is rapid acting. You give it, and in 15 minutes, boom, it's going to bring their sugar down. Okay? Subcutaneous injections. I look at some of the things that people write about the sizes of the needles. Understand that a sub-Q injection is a 45-degree angle. It's given in fatty tissue, in the abdomen, in the posterior upper arm, the part that no matter how much muscle you have, there's always fat here, right? Or in the thigh, but the side of the thigh, not the vastus lateralis, because that's a muscle. Side of the thigh has fatty tissue. Subcutaneous injections go there. Angles 45 degrees, right? Bevel's always up. I don't know if we even talked to you guys about that, but when you're giving an injection or starting an IV, then when you're looking at the needle, the bevel of the needle should always be up, okay? The gauge and the length of the needle, okay? Gauge is the thickness, length is the length. So for sub-Q, the length of the needle is 1/2 inch to about 5/8, 3/4 of an inch. The gauge is somewhere between, and remember with gauge, the higher the number, the skinnier the needle. So a sub-Q, 22 up to like 28, right? It's a skinny needle because you're only going into fatty tissue. IM, got to be a fatter needle. So IM, lower number, going to be somewhere around an 18 up to like a 21, okay? And the length of an IM needle is going to be longer because you got to get into a muscle. So now you're looking at a 1/2 inch up to 1.5 or even 2 inches long, okay? And the angle for IM, 90 degrees. So in other words, you're going straight in, okay? Okay. Diabetic ketoacidosis. I'll give you guys a quick blip on this, especially more for my night students. So with diabetic ketoacidosis, also known as DKA, it's a metabolic acidosis. What happens is person eats all this food, blood sugar goes up, and they don't take their insulin. Okay? And so their blood sugar is elevated, and all this sugar is just free floating in the blood. And a healthy person has insulin that their pancreas will make in response to that elevated blood sugar. So in a healthy person, I eat a bowl of ice cream and my pancreas goes, yeah, you did it again, but it sends out insulin, and insulin's the Uber driver. So insulin will drive through my blood and pick up all that sugar. Get in, get in, get in, and drive to all the cells and feed my cells. Have some sugar, here's some sugar, eat up so you can make ATP, adenosine triphosphate, energy. And whatever sugar's left, it brings to the liver and it stores it, okay? But now we have a diabetic and they didn't take their insulin and their blood sugar is 480. So all that sugar's in the blood and the cells are starving. And they're like, hello, we're hungry, we need to eat. Sugar's stuck in the bloodstream, it's not helping us any. Well, after a period of time, the cells are going to starve and they're saying, you know what, we can't wait anymore, so we will start burning fat for energy. We can't wait for the sugar. So your cells will start to burn fat for energy. The waste product of burning fat for energy are ketones, and ketones are acidic, okay? So the cells are burning the fat for energy, and the ketones are spilling into the bloodstream, which is making the pH of the blood drop, turning the blood acidic, okay? As that's happening, symptomatically, clinical manifestations, the patient will have breath that smells like juicy fruit gum and urine that smells like juicy fruit gum because the ketones have an acetone. You know how some fruits are tart, but they're sweet? Same principle, right? It's acidic, but it's sweet, okay? So fruity breath, fruity urine, they're going to have the symptoms of hyperglycemia. Remember, hot and dry, sugar's high, right? Cold and clammy, give them candy. So when sugar is high, they're going to feel feverish, almost flu-like, hot, not sweaty, not diaphoretic, hot and dry, okay? They're going to have something called Kussmaul's respirations, which is the body's way of trying to compensate for the pH that's starting to drop because they're going into an acidosis, right? So they're going to have this very deep, rapid breathing. It's called Kussmaul's respirations. Because the lungs are going, oh, we're in trouble. Jesus. All right, I know. Let's try to get rid of carbon dioxide because that's acidic and maybe that'll help. And she won't die. It won't help. But at least they're trying, right? Kussmaul's respirations. If we don't get this patient treated, they're going to go into a coma and they're going to die. Okay? That's diabetic ketoacidosis. It's a metabolic acidosis. They need IV insulin and IV glucagon. That's a very unstable patient that's in DKA. So if you see anything where it's talking about a patient that's in diabetic ketoacidosis or was admitted for DKA, that is an unstable patient. If I have IV insulin and IV glucagon and probably IV electrolytes running too, I am not stable. You are not delegating me to anybody, right? Just remember that. So they need hospitalization. They need treatment immediately. That's diabetic ketoacidosis. Any questions about any of the endocrine? I'm going to pause the recording. So talking about bedtime snack for diabetics. All diabetics should have a snack before bed. And what kind of snack, you ask? It's a good question. I'm glad you asked. They should have something that is a complex carb and a protein that's going to last them through the night. Okay? Because what will happen if you give them something with a simple carb, what's going to happen is blood sugar is going to go up, and then in the middle of the night, they're going to bottom out. So like, don't give them a Kit Kat bar before bed or a cupcake, right? What they should have is peanut butter on wheat toast or something like that, where they've got a long-acting carb and a protein that's going to carry them through the night, because there's something called the Somogyi effect or the Somogyi phenomenon. And what that is rebound hyperglycemia. They go to bed, they don't have the proper bedtime snack. In the middle of the night, their blood sugar plummets, drops. They don't wake up for it. Or maybe they wake up shaky a little bit or anxious, but they go back to sleep. In the morning, when they wake up, their blood sugar is going to be high. It's a rebound hyperglycemia. So you go in, you check their blood sugar in the morning, you're like, oh, geez, blood sugar's 280. We better give them more insulin. Don't do that, because the next morning, their blood sugar is going to be even higher. And it left people scratching their heads going, what's going on here? So the doctor's name was Somogyi, Japanese physician that figured this rebound hyperglycemia out. And it was that in the middle of the night, they bottom out and their liver will kick in and start pulling sugar from itself and converting it and gluconeogenesis, and their blood sugar will go up in the morning. And if you give them more insulin, it's just going to go even higher because their body's going, Jesus, we got to do something about this. They must have the right snack at bedtime that's going to carry them through the night and keep their blood sugar stable. That's critically important. And then the other thing that I want to talk about, even though it's not about meds or pharm, but diabetic foot care. And the board loves to ask about diabetic foot care. Number one, if you have a patient that has diabetes or they're pre-diabetic, always, always, always check for sensation on their feet. You're going to, at the sole of their foot, you're going to say, listen, I'm going to touch different areas of your foot. I want you to close your eyes and tell me, just say yes when you feel me touching you. And you're just going to poke toes, the sole of the foot, right? And see if they have sensation. Because if they do not, and that's diabetic peripheral neuropathy. If they do not, what can happen is they can get a wound on their foot and they don't feel it. So it gets infected, they don't feel it, and then it gets gangrenous and somebody comes over and visits them and goes, that smell, it's their foot. And then they go to the hospital and they've got osteomyelitis, which is an infection in the bone, and they get IV antibiotics. But because of the damage to the blood vessels, they have delayed wound healing, and we amputate. Bye-bye foot. And then that wound doesn't heal, that incisional site after that amputation, so they come back in and they chop off the rest of the leg. Can't say this enough. You know, control the blood sugars. Control the blood sugars. It's those erratic blood sugar spikes that cause all this damage. That's preventable. Preventable. Okay? So, for diabetic foot care, feet must be inspected every day. If they can't see the bottom of their feet, yes, they can use a mirror, or they can have their spouse or somebody, hey, just make sure my foot is good, right? There aren't any wounds or anything open. Never walk barefoot. Should always have their feet covered. Shoes. Never wear open-toed shoes like flip-flops or sandals. They never, rare that I can say this, no soaking of the feet. Old people love Epsom salts.
Yeah.
Why? The same reason they love laxatives, I guess.
Just like when the
Yeah, right? So, and I'm gonna soak my feet in Epsom salts. Please don't do that. Do not do that. You don't soak your feet. You shouldn't do it anytime, but if you're diabetic, never soak the feet. The feet should be moisturized, yes, but not between the toes. Because if lotion is between the toes, that is a dark, warm, and moist environment. Soon there will be a fungus among us, and the fungus will cause cracks in the skin integrity between the toes, which will then become a wound, which will then become infected, which will then become amputated. Okay? Diabetic foot care is critically important. Let's make sure you know all of that. What did I forget for endocrine? Questions? Questions? Any questions? Questions? Okay, so a couple more drugs. Methotrexate. Methotrexate is a chemotherapeutic drug. It is an immunomodulator. And so it will, as a side effect, suppress the immune system. So immunomodulating drugs, chemotherapy drugs, will suppress bone marrow. They're myelosuppressive. When your bone marrow is suppressed, it is unable to adequately make white blood cells and red blood cells and platelets, right? So a patient that is on methotrexate will be immunocompromised. They'll be anemic and thrombocytopenic too, but the big one is the neutropenia, the depressed white blood cell count, because they can't fight off infection, okay? So patient on methotrexate, priority is that immunosuppression. You wanna make sure, neutropenic precautions, no uncooked or undercooked food, no fresh fruits, no fresh vegetables, so like no salads, right? No live flowers, no live plants, avoid crowds. If they must go out, they have to wear a mask to protect themselves, okay? When people say reverse isolation, what they mean is neutropenic precautions, okay? So in other words, so the patient needs to be protected from us, not the other way around. We don't have to be protected from them, right? So if they're on methotrexate as a chemotherapeutic medication, immunosuppression is your big priority. You're watching that white blood cell count and you're making sure that they're on neutropenic precautions Also, you want to increase fluids because you want to make sure that their body's able to excrete the drug. Okay. Now, methotrexate's also used because of its side effects to treat autoimmune disorders. So autoimmune disorders like rheumatoid arthritis, multiple sclerosis, systemic lupus erythematosus, sarcoidosis, the list goes on and on. There are thousands of autoimmune disorders where the person's immune system, instead of attacking pathogens, it's attacking and trying to kill them. And so what can we do? We don't know, because we don't know what causes it. So the only thing that we can do is shut down their immune response and stop it from killing them. And so oftentimes you'll see methotrexate used with autoimmune disorders because it's myelosuppressive. We want that side effect. We want it to shut down their immune system. Cyclosporine, that's its whole job, is immunosuppression. That's what we want it to do. And that's typically used to take care of patients who have had an organ transplant to prevent rejection, right? Because if I give you a new kidney or lung or whatever, your body is going to view it as a foreign object and it's going to try to kill it. So what do? I must shut down your immune response so that you keep that new organ, which you need, right? And so that person is going to be on that immunosuppressant drug for the rest of their life, and they will always have those neutropenic precautions. And also, don't be fooled if you get a question that's like, an identical twin donates a kidney. Doesn't matter. That person that gets the kidney, even if the one that gave it is their identical twin, they still have to be immunosuppressed for life. Or they can have host versus graft syndrome, which is organ rejection, transplant rejection. So make sure you know that. Okay. Let's cut the farm and we'll talk a little bit about nutrition. Don't get too hung up on the nutrition part, okay? Let me give you an overview of it, like you gotta know. Fiber, foods that have fiber in them. The big ones are fruits, the skins of fruits. Fiber is something called cellulose. Cellulose, your body does not digest, right? It's not absorbed. It just passes through your digestive tract. But while it does, it grabs onto water. And as it holds water, when it gets to the large intestine, it keeps the poop soft. So it makes you poop easier, right? It's like nature's own stool softener. So fiber foods, the big ones are, fruits and the skins of fruits. Eat an apple, eat a pear, eat a peach, eat some prunes. Prunes are great for that. Prune juice. That's fiber. When we talk about protein comes, the biggest source of protein, animals, right? And so when we're talking about somebody who could be iron deficient, it's usually...
Yeah, what's going on with you?
We can hear you, mute.
I don't want to be too old.
Oh, sorry.
So with protein, animal products are your greatest source of heme iron, a complete protein. So beef, pork, chicken, turkey, right? Animals. People that are vegan don't eat any animal products at all, only plant-based. So the one thing that has the most complete protein that's considered a heme iron, soybeans. Sure you know that. So if the person's a vegan, gotta eat them some soybeans. Tofu is made from soybeans, okay? That is how they get their protein. Okay? So animal products are complete proteins. They are heme iron. So you eat a steak or a burger or a pork chop, or you eat eggs, right, which are a good source of protein. You're getting a complete protein, a heme iron complete protein. Plants, other than soybeans, okay, you can get non-heme, like spinach. Remember Popeye would eat his spinach? Yes, protein is in there, but you got to eat a lot of spinach, and it's a non-heme, incomplete protein in plants. It's the easiest way I can explain it to remember it. right? You can only get those complete proteins, that heme iron, from animal stuff and soybeans. Everything else that's plant-based, if it's plant-based, it's a non-heme incomplete protein. There's protein in it, it's just not as much, and it's not complete. 15 amino acid chain, but you don't really need to know that, okay? So that's the easiest way to remember it. So if somebody's a vegan, you know, they're not eating any animal products. Somebody's a vegetarian, typically, you know, they shouldn't be eating animal products, but sometimes they're lacto-vegetarians. A lacto-vegetarian will eat dairy. So they'll eat cheese and eggs and milk and stuff like that. Right? A pasho-vegetarian will eat fish. And there's protein in fish. That's an animal. I mean, I know it's not a cow or you get the point, right? So, you know, depending on the patient's dietary regimen, and that's why it's important to ask a lot of questions of your patient, because if somebody says they're a vegetarian, you need to ask them, all right, talk to me. Are you a lacto-vegetarian? Do you drink milk, eat eggs, cheese? Will you eat fish? Or are you strictly no animals or animal products at all? That helps with dietary guidance, okay? Okay. Let's see, vitamin K. Vitamin K, like I said earlier, we talked about warfarin. The green leafy vegetables are the biggest source of vitamin K. But it includes cauliflower, which I know technically is white, but when it grows in the ground, it's green. So broccoli, cauliflower, spinach, kale, quinoa, vitamin K. Potassium, just remember the word potassium in your head. P is for potato, O is for orange, T is for tomato, A is for avocado. And I put up the cheat sheet, right? Muskmelon, fish, raisins, all those things that are loaded with potassium. The Board of Nursing will never ask you, you know, how many micrograms of potassium are in an avocado versus a banana. Don't worry about that. So don't get hung up on this nutrition, guys. The basics is what you need to know. You need to know about protein, right? Vitamin C, citrus fruits, right? Orange juice, grapefruit juice, oranges, right? That they have a lot of vitamin C. Vitamin A, think carrots, beta carotene, carrots. Think about Bugs Bunny. He had great vision because vitamin A and beta carotene are for your vision. So vitamin A, vitamin C, we talked about, vitamin K, calcium. This is another one. Calcium, if you see an answer, like it's a select all that apply, and one of the answers is oatmeal. Oatmeal is fortified with calcium, but calcium's found in dairy products like cream and milk and cheese, right? And in order to absorb calcium, you need vitamin D. Vitamin D, 15 minutes of sun, 3 days a week. You have a substance in your skin that actually is activated by the sun that will produce the vitamin D that helps you absorb the calcium. Okay. Talked about fiber. Anything I'm forgetting with nutrition? Anybody? Anything that you want to know? No? Nothing? All right. It's 10:48. All right. Clear liquid diet. That's the last one. And then your time will be up. Clear liquids are liquids that, number one, you can see through. Okay. No dairy, right? But coffee and tea, and iced tea, and soda, ginger ale, right? Those are clear liquids. When you put them into a glass, you can see through them. There's no pulp or sediment or anything. Jello is a liquid at room temperature. The only reason that it forms is you have to stick it in the fridge. So when it's at room temperature, if you pour it into a glass, you can see through Jello. Jello is a clear liquid. Grape juice, orange juice are not clear liquids. They're the two exceptions with juices, right? Because they have pulp in them. So just remember, grape juice is a no, orange juice is a no. But anything else that you can see through, If it's tea or it's coffee and it's got sugar in it, sugar dissolves, sweetener will dissolve. You could still see through it. It's still a clear liquid, okay? Full liquid is clear liquid plus dairy. Clear liquid plus dairy. So now they could have a milkshake or ice cream, right? So just make sure that you understand clear liquids. You can see through them if they're put in a glass. And I'm giving you the answers to the exceptions, which are orange juice and grape juice, because sediment, right? Full liquids. That's it. Anything else? So I can take a little break before I do the next one. All right, I'm going to stop recording. So, ta-da.